Hello and welcome to Thursday Night Talk. This is a show where we discuss the week in Humboldt, the local issues, and the local personalities with local personalities. I'm Talvi'd. I'll be your local host for the next hour. What is the state of women's health in Humboldt County? Are services adequate? Are outcomes positive? And what about uninsured and underinsured women? How are they coping with an overburdened and underfunded health system? As well, what does healthcare even mean? We can get into all that thanks to our panelists today. We've got Rose Gale-Zoellick, Executive Director of the Humboldt County Breast and GYN Health Project. Mary Magubat, Director of Cal Poly Humboldt's Women's Resource Center, and Dr. Stephanie Dittmar MD from the Ikigai Physician Group. Welcome, everyone.
Hello.
Hello. I felt like with everything going on around the world, this was kind of an important topic. And health in general is an important topic, though, especially with the current changes on a federal level and ones that are trying to be pushed on a local level. It can be very, very iffy for specifically women right now. No offense to the men. There's healthcare issues out there that are very specific for them. We can discuss that in another show. So for today, let's just discuss what some issues are living in a rural community where luckily it does have a more progressive outlook here than, say, Mississippi, and what that means. So I'm just going to start this off with a softball question for everybody, which is what is healthcare like in Humboldt County right now? Rose, I'll go with you.
All right. So at the Breast and GYN Health Project, we mostly help people who are diagnosed with cancer. We do get calls from people who, because our name is Breast and GYN Health Project, sometimes people think we are a health center. So people will call and they'll say, I'm new to the area, or I've got a breast lump and I need an examination or a mammogram. So we help field those phone calls. Boy, there are long waits for people to get into primary care right now because of the healthcare shortage with primary care as well as with specialty care. Sometimes people have long waits. If people call us, we kind of are able to kind of help people navigate to get a pretty quick appointment for a breast exam and a mammogram. But a lot of people don't know to call our organization. So we're a resource for people in the community.
Yeah, I think the landscape is pretty challenging to navigate across the board, especially for women and some of the health needs that come up. Both the people that have been residents here in the county for a long time, as well as people recently moved up here. The consistent phone calls that we get at our office is, a lot of concerns where they've called around to multiple offices and there's no availability to make appointments, or there's a long wait list, or there isn't a wait list. And so it's just that primary care is your first entry into any aspect of your physical body and that health. So in our particular county, the shortage of primary care is a big deficit. It's one of the reasons why the residency was created, and the family medicine residency in Eureka was created, was trying to hopefully address that issue over the course of the long term, is to hopefully train family medicine doctors to hopefully populate our area in order to be able to access healthcare. But the reality is that not just depending on your insurance type, but just the sheer number and volume of people and the actual number of physicians and non-physician providers. It just doesn't match the population need.
Yeah, and then I can kind of chime in. Rose and Stephanie really did give a really good overview on just like what healthcare is like outside of like throughout all of Humboldt County. But coming from like a more student perspective and me working at the Women's Resource Center, it's definitely really hard to like announce what resources available on campus for students. A big one is the transportation. Most students like there's a general parking issue on our campus, so students don't always just bring their own vehicle or just have their own vehicle. So if they're going off campus to get bigger medical attention, it's really hard. And there's a lot of resources on our campus, but there's only ever so many individuals who can like do the outreach and inform students, and not only just inform them, but allow them to be comfortable in having those discussions. And throughout my time working at the center, I think that's a big thing of like, how can students of all backgrounds just feel comfortable talking about sexual health, reproductive health, and being able to advocate for themselves and getting those resources. So yeah.
So there is a talk about physical health, though it does seem like I've heard a lot of stories of women going in and it being everything is attributed to their mental health, because they're just crazy. The pain isn't real. There's and I've heard that happen actually quite a bit out here. I won't say any specific doctors' names, though women do talk. As Humboldt County is finding out, we do talk to each other and let each other know where the safe spaces are and where our actual concerns will be heard and dealt with, and especially in a realm where there is a safety factor too, of like you said, being comfortable going in and discussing something, knowing that you're not going to be shamed for anything. Like everybody has odd things happen to their body, though a lot of people, especially students, I imagine, are kind of stepping out into the world for the first time. So whatever their family dynamics were can really affect how open they are. Or if somebody has, say, a spouse that's very overly protective to a negative point, it can really affect the feeling of safety going in and talking to a doctor, because what if they find out? And I'm just wondering if there's steps to ensure that that isn't happening, and what those steps are, and what women can expect.
Talvi'd, you're spot on. That's the data that we've been demonstrating literally since the 70s in the United States, where women are discounted for their beliefs, experiences in the medical profession. In fact, oftentimes when we discuss women's health in this kind of a context or others, we focus on, although it's very important in terms of reproductive health, most people don't realize that most females die in the United States from heart disease and cancer and strokes. So the reality is like even how we like frame the question of how do women seek health, the heart disease outcomes for women are poor because they are discounted, because they often don't present in the same way as a typical left-sided chest pain where men tend to present with. And instead, the generalized ill feelings of fatigue get misattributed to psychiatric components, or get missed entirely because they're discounted. So you're exactly right. It's one of the challenges of women's healthcare across the U.S., but especially here in Humboldt, where the number of people that we have in terms of our clinical training and our clinical status of being up to date, or even how we do or do not provide self-reflection or ongoing evaluation of our own practices to see where our own biases are coming into play. And it's even worse if you're a female of color. If you're a female of color, then you are even more likely to be discounted and even more likely to have worse outcomes. So there's clear data that shows that. And that's what's particularly frustrating as a physician and a patient, is that you know the outcomes, and yet we're not making any bit of a difference. The data over the course of decades show that our outcomes are just getting worse. They're not getting better.
If people have a breast or GYN health concern, one of the things that's really cool about the Breast and GYN Health Project is that we're not a medical facility. We're a cancer resource center. So we have time for people to come in and discuss their breast and gynecologic health or cancer concerns. So we can validate people, help them navigate, help them be heard and maybe feel validated. So we're a great resource if people want to call or if they'd like to come in.
Yeah, feel free to give the number out for the center.
Oh, sure. It's 707-825-8345.
Mhm. Yeah, and I could speak to just how I don't know if it fully answers your question, but speaking to the point that Stephanie had made about just like women of people of color who often go in kind of getting disregarded, like there is that intersectionality aspect of getting like medical help and especially in the realms of like menstrual reproductive health. That's what I do a lot of work in at the Women's Research Center, getting people to be comfortable in just being able to talk about that, and that we give out free resources for it. So there's that component of education to it also being like, we're offering you a resource that your student fee dollars are like getting like put towards. And our biggest events usually often lie into these informal conversations that Rose was kind of mentioning, like you're not like a clinical center, but you can be a resource to ask these questions and just feel like, hey, this might sound dumb, but it's not dumb. Like you just need someone to talk to because maybe your prior experience is like you just didn't have someone who was knowledgeable in giving you those important bits to feel comfortable within your body and like asking for those resources. And it's really interesting because we'll go into depths about talking about your first time with your periods, and someone will kind of go like, that's like a little TMI. I'm like, is it? I think like we all have these own experiences and our culture is telling us it's a taboo. I kind of wanted to share a recent situation where my coworkers were out tabling. We're giving out for any student who's in the Humboldt County area and need menstrual products or like fentanyl test strips or any of that sort of resources, we're tabling and we're offering it every Tuesday and Thursday from 11 to 3 p.m. And a group of middle schoolers came by and they were talking about it. And one of the staff members said, like, these are middle schoolers. And I was a little baffled that in this current day and age that menstrual conversations or getting the needs for your resources is too much of a convo. Like it shouldn't be had within younger people. So I can imagine what it's like for people who are in college or just like 18 years and up, like how they can feel just trying to get any type of conversation, discussion, questions asked. So yeah.
There's definitely a differential in the way women are treated in the context of identifying their sexual health needs versus others as well. We definitely have all kinds of stereotypes in our culture as to who and what and where we should talk to, but the element of safety that Talvi'd really spoke to earlier is actually a really big concern in this particular area. The reality is that many women, a majority of which actually have had some level of abuse or assault. And so when you really layer on these multiple types of, adverse traumatic events, it really brings to the forefront why accessing care is even harder for women in that particular regard. And quite honestly, we've had lots of women have really bad experiences. And so that's one of the things I've seen in clinical practice repeatedly, in the context of even being somebody who performs, women's exams and pelvic exams, you know, how you approach everything really makes a huge difference. And one of the ways that I think I've always tried to assess this with my particular perspective is always asking about those questions before we do anything. Because if you don't ask, you don't know. And reality is that, you know, people very much trigger on certain sounds, certain positions, certain odors, whatever, and you don't want to add your experience to their trauma. So really being open and having an ability to have a frank conversation with people and their physicians is rare. And that's the feedback that I generally tend to get as somebody who does that. Is like, no one's ever explained this to me. No one's ever talked to me this way. No one's ever asked how I felt about this. And so it's one of those things that it's really a challenge on our end, I believe. I think the onus really is in the medical profession to do better. And unfortunately, I don't know that that model really exists here, quite honestly.
What would be required to change that model?
I think it really requires a self-reflection of our medical community. I think that's kind of the reality is that we are in vulnerable positions as patients, right? So I'm going to shift a little bit. As a patient, we're in a vulnerable position where I'm not going to already, when I've been victimized repeatedly, complain and put myself out there at risk, asking myself to be re-victimized to describe the difficult situations I've been in. And so none of the formal feedback that medical professionals rely on to change behaviors exists here. I've unfortunately been in multiple situations over the last 13 years here in the county where, my recommendation to multiple people is to bring this up with the regulatory boards, bring this up with the physicians, with the management directly. But you can't when you're struggling, when you're really struggling with the outcomes that you've been experiencing, right? It's the same sort of situation when we talk about legal outcomes when people are trying to go forward with rape and assault cases. You're asking the victim to be victimized, and then in the medical profession, that's kind of what happens.
So that is a very important topic. I think let's head to our first break real quick, and then we'll come right back and discuss more on that, because the underreported nature of things is a huge important factor. The fear of even going and saying, I think I stubbed my toe, because you're so used to not being listened to is such an important factor. And I'd like to get into that. So you're listening to Thursday Night Talk. We'll be right back. Welcome back to Thursday Night Talk. I'm your host, Talvi'd. I am here with Mary Magubat, Director of Cal Poly Humboldt Women's Resource Center, Dr. Stephanie Dittmar MD from the Ikigai Physician Group, and Rose Gale-Zoellick, Executive Director of Humboldt County Breast and GYN Health Project, and we are discussing women's health. And right before the break, Mary, you had mentioned that getting resources to students include fentanyl test strips, which I really don't, I'm always afraid to say this incorrectly, because I feel like if no one blames the rapists, they blame, you didn't check your drink, you didn't have the right things, you left your drink on the table, or, you should have known not to trust that person. It's never like, no, rape is caused by rapists. Like, let's just be honest here. Sexual assault is caused by people who sexually assault others. And I don't ever want to victim blame, though at this point in my life, I do realize there's a lot of things you can do to protect yourself. It's not your fault if something happens. It's not your fault if you didn't protect yourself, or somebody didn't protect you, or you didn't protect somebody that you loved. So that's a very important aspect of health, is just knowing, which that's a scary part too. It goes right back into what Dr. Dittmar was saying, which is, you're so used to being told that it's always your fault and that it's nothing. if it is something, it's something you did, why would you go to a doctor and say anything? And especially be put through all of that, which there's a lot that goes into claiming if you were injured by somebody, that it can be it's very uncomfortable, to put mildly. And I'm just wondering what there is for, well, I'm curious, Mary, what there is going, I'm kind of curious in every aspect, what kind of discussions happen within your realm of workspaces and expertise and your clientele. But let's start with Mary on this one, because the student population is very vulnerable. And it's kind of bothersome that women are being told, here's a fentanyl test kit, and not the boys told, how about you just don't do that? And I know there's girls that also are horrible, but that goes into everything of what is the education out there about consent, about boundaries, about learning to read people.
Mhm. Absolutely. Yeah, you make a lot of good points, Talvi, for sure. And like, I think that's why a lot of the work, especially at Humboldt, we have a relatively good campus culture on like consent culture and like harm reduction. I feel like every health-oriented org that happens on campus is very adamant about ensuring like not only are these resources like available, like how do you use them? There's like Narcan training videos and like in-person demonstration. There's just like overall like a lot of conversation and opportunities for students to come into our office hours and talk about how to use these resources. Why would you need to use these resources, like, and why they're important to just keep on you. And overall speaking to just kind of the social just perspective on a lot of these issues is that we still are operating in a very like patriarchal society where like men can do no wrong in all these decisions or in all these aspects. And like with the current months and the end of my spring semester of last year, like it was a really big topic within our center to talk about how like rape during is used as like a weapon of war for a lot of big issues at this time, because in a lot of the conversations happening in Israel and Palestine, like both parties are very much explaining that they assaulted our women, and there's just no like common ground of like, that's just wrong in every sense. Like, and so this aspect, like, who do we believe in these situations? Who do we want to believe? And there's a hierarchy of belief from a certain group is like really just disheartening. And that really, I think we just kind of saw a lot more of this within our time in the school year. And that's why it's just so important to really inform students in every which way, even if they're super uncomfortable to have. I think the more that people are exposed to these conversations, they don't become just like completely like they're not strangers to it. Like they know how to go about it, and they're very much empowered to have these conversations and then do the work of like teaching other people. I know for me, like my comfort level is just like over 100% in having all of these conversations with students and my peers, because I think my positionality was I was very privileged to have those access. I had a 9th grade teacher who explained every single thing about drugs and how it impacts your body. And that was a lot of harm reduction on my end that, nowadays with health education, students are getting lied to in those classes. And that's setting them up for like, not failure, but just like then harm will happen, like we're allowed to make decisions on our own. But if you can't give us the resources and education, like there's just this expected outcome that no individual should be blamed. It's more so the system.
I'm gonna move on to Dr. Dittmar. What sort of kind of safety safety conversations? I mean, it really all encompasses everything about women's health. It's a societal issue. I'm understanding that part, though. It's also like, what do we do?
Yeah, the intimate partner violence is a really big topic for women's health. it's one of the things that we'll actually do in primary care is sometimes we do have to really help women troubleshoot through that process and work through like the Humboldt domestic violence line and call from an office medical visit, because that's a protected space for that female. She can come in saying that, there's a concern about her asthma or coughing, or I'm sick, or I have a UTI. And in that setting, you really can sort of reach out to people. And so it's part of the idea that we're supposed to be doing is we're supposed to be screening for intimate partner violence every time we encounter a female, specifically to pick that up because it is so common. And so the reality is the medical office could be a safe space for people if we can do so. At the same time, like it's a challenge in our particular environment across multiple settings. We have a major healthcare delivery system here that's religious based and has a lot of its ethical religious directives that inform the medical decision capacity in that setting. So you already sort of have an unsafe setting for a lot of women and people that identify as women in that setting. So you really kind of have a disparate already sort of background and setting. And so the reality is that that level of safety at accessing care is a big problem for people. And we don't necessarily have systems that allow for establishing a lot of the important patient doctor relationships because of how the structure of medicine is. So you can't really get to a lot of things in 15 minutes as your sort of time is up and it's time to go see somebody else. How much can you really accomplish in that kind of a setting is difficult, but yet all the major healthcare systems in our county create appointment types that really sort of also prohibit to a certain extent structurally safety. So it's a challenge. It's one of the nice ways where, you know, being somewhat self-aggrandizing in the setting that we've been able to create a different practice model where our patients have 30 or 60-minute visits with us, sometimes longer. I had a 2-hour visit today with somebody with one of my female patients. So it's like it's really structurally difficult when the structure doesn't allow for what the patient needs.
Yeah. And at the Breast and GYN Health Project, because it's such a big, intimate partner violence is such a big issue, we hear about people struggling with that as well as struggling with a cancer diagnosis, super hard. So we will take the time to help them with whatever they need and whatever they would like to do.
So there are, I don't have them in front of me, and I should have thought of dragging them up and being like, in this study back in, though they're just on every front, like I don't know if this one's true, but I keep hearing it repeated, and that's the number one cause of death for pregnant women is their partners killing them, is murder. And then that for women who, or females who get cancer, it is so likely that their partner will leave them. Like just, I can't remember the exact percentage rates, but just exorbitantly high. Whereas if a male gets cancer, it typically is that their partner will not leave them. And it's just kind of scary. Like what kind of society led, like what kind of thinking even led to that. And I'm curious about the pregnancy one, especially because has that statistic gone up because of the lack of healthcare around the country? The lack of women having choice in what's going on. I mean, it's an expression of the extremist, control that they're under, though how, like what protections are there for people who are in positions of not having the ability to control things? Like, say they do go to the doctor and they have a smile on their face, like what do you do?
Yeah, so to clarify, so amongst pregnancy-related deaths, right? So if you take that as a category, mental health conditions as we categorize those, in terms of suicide, overdoses, substance abuse, that pregnancy related in that context is almost a quarter of the cause. So you can include that as IPV in the sense of like depression, suicidality, substance abuse and violence. I don't know the subset of that. But then you really get into some of these other components of women's health related to bleeding risk. The reality is that women bleed tremendously during the course of a delivery process, and the reality is that postpartum hemorrhages is really up there, and or intrapartum hemorrhages. And so excessive bleeding and hemorrhage, because so much of the blood volume of a female is really dedicated to that that pregnancy, you can literally bleed your entire blood volume out in minutes. So if you don't have a systematic way to identify, to diagnose and treat the situation, then that's one of the leading causes of maternal mortality. And that still is, even in our California and our state. So it's not just another problem. And then the cardiac issues. I rose that up earlier because we really undertreat women. We don't get to hypertensive goals, and we are obese. We are struggling with prediabetes. We have multiple medical conditions that then impact the pregnant state. And the reality is that we don't do a good job at following those, treating those, diagnosing those, and taking care of them. Instead, there is oftentimes a very paternalistic direction in the care of women that just sort of like say it'll be okay. And the reality is like no, that there's a significant risk around a reproductive state. And so identifying people and really giving them the tools and the knowledge to take care of themselves, because that to me makes more sense, is to educate people and have them have an awareness and control over the situation through education, through them being able to understand what's going on with their body and bringing stuff up. The problem is when you bring it up and the medical doctor doesn't hear you or the nurse doesn't hear you, then we run into the problem of misdiagnoses. But that's really, really important, Talvi'd, is like our maternal outcomes in this county, in this state, in this country are poor because we don't listen to females. And the studies show that if you're a female, again, a Black female bringing up information about what you feel in your pregnancy, it will be discounted. Or females of color have even worse outcomes, even those female physicians of color, right? So even when you know the words to say and you're advocating for yourself, you still have poor outcomes. Absolutely is just quite honestly, it's a travesty. And the fact that at the national level we continue to struggle with, basic human rights of females is we're no different than what's happening at the nation here locally.
So on a non-pregnancy stance, because we're in California, and California legally you can have options if you know about them. Though, what are the safety what's the safe data there for women seeking? I know there's a Planned Parenthood out here that people can go to. There's obviously the resources at Cal Poly that people can go to. Though, what does that typically look like for somebody out here, especially? I mean, pregnancy.
Who's trying to access?
Well, yeah, who's trying to
services?
access it, and is it dangerous?
So it's always dangerous for that situation because we don't live in a county that's blue, right? The reality is like our local clinicians have received threats for participating in these things. It actively impacts their decision making around wanting to participate in some of those services. But Planned Parenthood has been a staple in this community for years, is really well supported here, and has been a longstanding support for female for all reproductive rights, quite honestly, and all sexual health. But the reality is, yeah, we are in a little bit of a safer space in California. But again, when as when a significant percentage of your healthcare is delivered within a religious context in our county, and it's the main center where there is actually obstetric and gynecologic care, that's different. That doesn't necessarily apply in a lot of other counties where you have multiple types of healthcare organizations. And resources also include transportation and access. You know, a lot of times people do not have access to transportation here. There's not a single public bus that goes to Ferndale, as an example. You know, you have lots of limitations of access. Students on your end as well, like you said, parking. A lot of people do not drive. I've been, I've been repeatedly, confirmed that, a lot of people in this county just do not have access to transportation. So asking a woman who is coming from Southern Humboldt to go all the way up to Arcata isn't necessarily a reliable access point for them, right? So I think that the reality is we do have some really good services if people can access them, and when they are accessed, they're very helpful. But I don't think that we have here in Humboldt County a clear delineation of like, oh, this is a safe space, because we don't. We have disparate politics. We have very disparate outcomes. Trying to get data out of the Providence healthcare system regarding outcomes for patients of various ethnicities over the last 10 years has been met with repeated denials. Right? We don't look at our own data. We don't look at our own outcomes here in the county from this particular lens.
So there's the factor of a lot of healthcare being, while we're discussing it, it seems like dealing with young women, women who are still in the age group to potentially have children. Though there is the aging women group that I feel like is often left as invisible. Sometimes they're not so their concerns aren't heard. Like a perimenopause, menopause, postmenopause is not something that's really very well discussed. And I think it's interesting because I've personally had a friend that she started going into it when she was like early 30s, and that was unfathomable to me. And I still am not fully, like my mom tells me, and I'm like, oh gosh, well, that's eventually going to happen. Not just that, there's the bone density loss, obviously the hypertension and heart conditions that just never get addressed. And so I'm kind of curious with how the older women of Humboldt County are faring. Well, especially because of the income discrepancies there too, plus the that this is known for services in this area where a lot of retirees come, or I feel like there's a lot more women in the retirement homes, I guess we can call them, than there are men so often.
I do want to add, like, just kind of like a small point where, like, at Humboldt and just like overall in the CSU, like California school system, like when older individuals really don't get any resource or attention, like the way that so far the CSU admins have been kind of operating and looking at our public education is in a business model, and they've like publicly mentioned it in that way. And often those like older women who come to like the Women's Resource Center, like I often feel a little bad that we don't have the resources, and like no one's ever kind of guided or just provided more thought about students who are just like non-traditionally going through college, like people coming in with like they're a single parent or they have a family, they have a full-time job while also trying to get a degree. Like those things are just also kind of in the vein of conversations where like it's kind of looked down upon, but at the same time, congratulations. So it's a lot of mixed messaging. And I think in the county, I've definitely felt like you need to come through with really concrete answers. And if you don't, then we're not going to help you. And it has been really unfortunate. And like, I also wanted to touch on Stephanie's previous discussion about like, just like accessibility beyond just like the resources. Like there's always a limited amount of supplies, which is what I think the admin like to hold on ours. Like it's like we just don't have the money for it. And so all of these student-led programs, faculty who aren't even really working in that specific department, but just doing the advocacy work, they're working overtime to get stuff for the campus community or for the community in general. And that's just like a passion project or advocacy work they're doing, not even set into their own job description, because we can obviously tell like this is such a need. We have like birth control pills at the health center, but there's like only a certain amount of supply there. It's great that we have it, but it would be better that we have enough so then everyone feels comfortable coming in and feeling like they can get these supplies. And I was also going to mention that like there's like that emotional component, emotional support component throughout all of these discussions. It's like it's very textbook when you go into a medical center, or if you're like, I need to go get my medical supplies for like my abortion pill, but like, you know, are you really wanting to sit on the bus, getting over to Eureka and then just kind of sitting with yourself? You know, like there's no one there, or like there's not too many resources for people to really just call and be like, hey, I just kind of want to talk about this experience and just feel seen and validated, you know? So those are also like encompassed issues that's coming at hand with this.
So we're going to take a real quick break, and we're going to continue this discussion after that break right here on Thursday Night Talk. Welcome back to Thursday Night Talk. I'm your host, Talvi'd. I'm here with Mary Magubat, Director of Cal Poly Humboldt Women's Resource Center, Dr. Stephanie Dittmar MD from the Ikigai Physicians Group, as well as Rose Gale-Zoellick, Executive Director of Humboldt County Breast and GYN Health Project. And we are discussing women's health, quite a bit about it. This went a lot deeper than I thought it would go, though I'm glad for that. I'm very grateful for all of you being on this show. Though I wanted to get back to kind of the generational experiences of older women in the community, just because I do feel like I actually have a listenership that it is Access Humboldt that veers older. And I don't think there should be a stigma with any of that. Goodness, if my mom were here, she'd tell you all about it, because she just has no filter, which in a lot of ways is really great, because it, you know, somehow I ended up more on the conservative side, like, oh, I want to talk about things with my mom. And then I got older and I'm like, actually, that was really useful to know. So, so there's that, though. For those listening, what are the resources out there, and what are the expectations of healthcare, or of the health that they should, maybe not should be receiving, but that is out there for them? Because I know it's cancer affects all ages, though I do think of cancer as being more likely to happen as one gets older. You've been here a little longer on the planet, the chances get higher. So I kind of want to jump over to Rose and just see what things are like, you know, over there in that realm.
What resources might be available? You know, sometimes I think Planned Parenthood is really an overlooked resource for our community. I know that there are that they provide some cancer screening for sure, and I'm not sure quite how they used to help people who were menopausal. I'm not sure about the newer clinic protocols, but I know that women in their 40s, perimenopausal women for sure, get care at Planned Parenthood and have a good experience. There are programs for free mammograms at Matterford Hospital through the National Breast Cancer Foundation. There's a program called Family Pact that's a little teal card that help women of all ages, if they're able to have children, at lots of different clinics and at Planned Parenthood and other facilities. So what other resources? There's a program in the state where if someone is getting cancer screening, they're income eligible and they don't have other insurance, there's a program where they can get screening and then get rolled right into a breast or cervical cancer treatment program. So we are so lucky to live in California compared to other parts of the country. So there are resources out there, especially with the Affordable Care Act being passed years ago. There are many more resources than there used to be. So if people have questions about financial access to care, they're welcome to call us, or if they're part of the Open Door System member services or United Indian Health Services, member services are super helpful.
The difference in generational experiences, Talvi, is a particular interest of mine, and I'm thankful that you brought that up, because that is it's a next level of not listening to women, in the sense of yes, there's a reality of how bodies change, and actually Dr. Jennifer Gunter's books on this topic I always highly recommend to people. The Menopause Manifesto is one of my favorite books. But it's a situation where, yes, there's a lot of changes to the body, and being listened to and heard, and having somebody walk through some of the options that are available really has shifted quite a bit. There's been a pendulum swing in this area for quite some time. And so we've gone from all the way from the Women's Health Study in the 90s to now being much more liberal with how we look at hormone influences on our health, and what we can and should be doing at this point in time. But again, that starts with your primary care, right? It starts with your primary care and access, right? The FAMPAC program that Rose mentioned is great, but it's another example of there's lots of these biases in medicine, and FAMPAC will not cover things if you are not able to reproduce. If you have a tubal ligation, doesn't cover you. So there's this bias in women's health, specifically towards reproduction. And in reality, the other side of that's true, Talvi. We don't sit here talking about like what's the hormonal deficits of men as they age, in the sense of how that influences that, and do they go crazy, and how does that influence things. But we do with women. We have an overabundance of concern for mental health issues. But the reality is there's biologic changes. And I wish people would really feel more comfortable bringing those stuff up, and then feeling heard, and then really kind of walking through those things. But there are increasing cancers as we get older. As you're right, we get older. The more trips we make around the sun, the more times that our cells can make changes. But that's of all areas too, in the sense of, as we get older, not treating our high blood pressure, not treating our pre-diabetes, not treating our high cholesterol. That's the kind of stuff that comes back to like hurt us in our older years. There's sort of a self-selected nature to people that move here and stay here, right? Is we tend to see a lot of people that avoid medical interventions and want to do things naturally, but even in the face of their attempts to try to do that, but yet year after year have high cholesterol, high hypertension, the eventuality of that natural course is a bad outcome. So it's part of the thing as we age too, is as we age as women, it's like, is understanding what is the hesitancy, and how do we actually educate people to understand what are the outcomes difference. Even if you do eat naturally and you do eat well, your LDL cholesterol is still 180. This is a problem, right? So the reality is like, especially for our older females, like trying to have them understand what the risks are. Here are the tools. I do this in my exam room. Like, here's the website. Here's the statistical chance that you're going to have an adverse cardiovascular event in the next 10 years. Here is your lifetime risk. This is what I'm talking about. It's not a generic sort of idea. These are the numbers. Are you willing to take a 1 in 2 chance that you're going to have a cardiac event or a stroke in the rest of your lifetime up to age 85? Like, and so when people are given information, then I feel like they're able to make decisions that are in their best interest versus maybe not for them. You mentioned osteoporosis, Talvi, and that's another undertreated underdiagnosed. There's a condition, and people really, as women, do not understand how much of an impact that is. If you break a hip, the likelihood of a blood clot, of a pneumonia, ending up in a nursing home, losing your independence, the drastic change that occurs is huge. But again, we don't diagnose it, and we certainly have a hard time getting people treated.
Well, I think there's also a factor that we haven't really mentioned, and that is the ever-present pressure for women to make themselves smaller. And I think that has a huge effect on health, on diet, on mental well-being, which of course what happens in your head affects your body. Which we're unfortunately slowly out of time. We can have a whole eating disorder episodes and body dysmorphia disorder episodes another time, because I think that one's super important. They're all super important. Everything's super important here, especially when it comes to health. Though it is about time for the round robin. I wish this could be a 2-hour episode, though that's okay, because there's so much more that we did not get into, and I value all of your expertise. So what the round robin is everyone gets about 3 minutes. You're going to discuss whatever you want the listeners at home who are listening on 96.7 FM on the radio, or if they're tuning in on YouTube, or if they're watching on our Access Humboldt channels. Whatever is in their head, put something else in their head now. Or go along with it. I don't know. If you can read minds, that's pretty cool. So let's start with Dr. Dittmar. You get 3-ish minutes.
Thanks, Talvi'd. Yeah, I think what I would like to leave people with is a sense of validation of, yes, this is hard. Yes, what you're experiencing is challenging. Yes, you need to be able to have the fortitude and the persistence to bring forward your concerns, even if it takes multiple times, multiple efforts across different healthcare settings. I think it's also helpful for women to bring somebody with them to their appointments, to be able to have a second pair of ears, a second pair of eyes, another advocate that can also bring up concerns when you're kind of deer in the headlights, not certain what I'm supposed to do. Then your friend and your advocate can also step in for you. And I think the other component, lastly, is if you're uncomfortable with something or you feel like you're not being heard, call it out in real time. Call out your experience and what you're feeling right then and there before it gets worse, before it escalates, before you then don't have an ability to have your concerns addressed, worked up, before you get sicker. And so that's the other thing is, like, we as physicians, if we are generally confronted with something that we are missing and somebody is vulnerable, that shifts our natural position from out of the doctor brain into the humanistic. I have a female in front of me. I have a mom. I have a sister. I have somebody who's struggling. And then you get to a different level. So be courageous and try, because when you do, oftentimes you're met with a surprising level of support.
Thank you. I just want to ask one more question on that one. What are the type of words to say if you have a concern that you think a doctor will listen to you if you bring it to them, or nurse practitioner? I've heard the phrase document that you're denying me the exams or things like that.
Yeah, so there's a couple different tones. So the one that you're mentioning is, so you were denying me this particular study because of this. You're refusing to order the study because of this. Those are considered more confrontative, right? That is sort of like ultimate. My first always approach is sort of in that first stage of, I don't feel like I'm being heard. I don't feel that my symptoms are being validated. I don't think I'm being taken seriously. I feel this is what's going on, and I don't see you looking at my face. You're looking at the computer. I don't see that you have empathy for my situation. Like, bringing it back to the whole I feel statements, because that is really what is what we should be centered in. What am I experiencing as a patient? And is my doctor seeing what I'm experiencing? So that's always in my opinion, a first step, And if we still can't get past that, then I think it's time for confrontation, right? Then I think it's more of that next step.
Well, thank you. Thank you. I really appreciate your time. Rose, your few minutes are up now.
All right. I was thinking about when we came on the program about the importance of people getting their pap tests and their mammograms. I know that especially since COVID, I think things got a little out of whack with people getting those really important screenings, especially pap tests really do save lives because it detects cervical cancer really early, and the HPV vaccines do too. So I'm putting a little plug in for people to take care of themselves and just make sure that you get those important screenings done. And then I really liked what Dr. Dittmar said about being your own best medical advocate. That's a really important aspect of taking care of ourselves. And getting what we encourage people to do here at the Breast and GYN Health Project is to go and get copies of your medical records so that you can see and you can have, look back years later and see what's going on. And if you have hard copies, if things are no longer in a medical electronic medical record, you have your own copies so you can take ownership of taking care of your own health. I think I may be close to getting out of time, so I'm going to hand it over back to you, Talvi'd.
Thank you so much for being on the show, Rose. And hopefully, I know you gave the phone number earlier for some things, but hopefully we can get we'll just post it on the screen, the Humboldt County Breast and GYN Health Project phone number up there. So if you want to say it out loud real quick.
Oh, sure. It's 707-825-8345. And check our website too. We have a ton of information on our website.
Great. Thank you.
Thank you.
Mary.
Yeah, thank you, everyone. I'm definitely directing my last 3 minutes to everyone who's like listening and like have resonated with a lot of that we've talked about today, or just know people who will resonate with the conversations we were having. And I want y'all to feel empowered in yourself, and hopefully that you can empower other people in having these conversations and informing them of the research that's around in Humboldt County. I do think like we're a community, regardless of our different backgrounds and experiences. Like that's what all makes this like a community for one another, makes this time or these situations like a lot easier to navigate. And they're not easy conversations, but we can try and break through that stigma and feel like this is a normal conversation we can have in our everyday lives. So hopefully that's what sticks. And at the Women's Research Center, we're open for all collaborations. Like we partner a lot with people on campus, off campus, and the more the better, so that everyone in the area can kind of, support one another and give out resources when need be. So you can email us at hsuwomen@humboldt.edu if there's inquiries of that sort, or just have any questions for me or for anyone else at the center. And we're really active on our Instagram at humboldt.wrc. And yeah, come through on Tuesdays, Thursdays from 11 to 3 p.m. if you need any menstrual products, fentanyl test strips, condoms, enzymes, all of the sorts. So yeah, thank you.
Well, thank you so much to everyone. It's about all the time we have today. Thank you to our panel, Mary Magubat, Director of Cal Poly Humboldt's Women Resource Center, Dr. Stephanie Dittmar MD from the Ikigai Physician Group, and Rose Gale-Zoellick, Executive Director of the Humboldt County Breast and GYN Health Project. We'll be back next week with another Thursday Night Talk. And if you have topics or suggestions for this show, want to make some commentary on it, please email us at kzzh@accesshumboldt.net and kzzh@accesshumboldt.net. And just a reminder, this show will replay on Friday evening at 8 p.m. right here on 96.7 FM KZZH. And you can also watch the show on Channel 12 if you have public access television on one of Access Humboldt's TV channels. As well, look up Access Humboldt's YouTube channel, because you can get hours and hours and hours of me talking to all your local favorite people right here on Thursday Night Talk. I'll see you next week.